Okay, so hi everyone, my name is Laynie, and before we get started, I'll just show our disclosures here. Just so you know, by my way of training, I'm a genetic counselor. My home institution is University of Pennsylvania, and I have the pleasure of consulting with some of the groups listed there. And you can see Lauren and Paul's disclosures as well. So today, we're going to take you through a little bit of background on what are the genetics of ALS and related conditions, why does genetic counseling and testing matter as part of ALS care, and talk a little bit about some innovative ways that we and others are working to try to expand access to these types of resources and services, and give some food for thought for where we can go next. So before we dive into this, I recognize that not everybody here thinks about genetics day to day the way that I do. Certainly many of us have this as a core component of our roles or our lived experience, but just wanted to give a quick refresher for those of you who might not have thought about genetics in a while. Genes are sort of what we think of as the instruction manual for the body. There's a DNA code that tells the cells how to function, and if there's a typo in this DNA code or a mutation or pathogenic variant, it can disrupt the meaning of that genetic code and cause something to go wrong in the body. And so the example here, just by changing one letter, you can see how it can change the quote-unquote meaning of the sentence, which can lead to a problem in the body. And so historically, there was this sense that ALS wasn't a genetic disease. For most people, it was sporadic, apparently sporadic, quote unquote. And so, yes, it's true that the vast majority of people who have ALS don't have a single identifiable genetic cause for their disease, but a genetic cause is much more common than we once thought. So many of you might have heard the stat that only about 10% of people with ALS have a family history of ALS or related conditions, which is absolutely true. Among those people that have a known family history, we can now identify a genetic cause in the vast majority of those people. There's still a gap, which tells us there's still probably new genes that we need to discover, new technology is needed to better capture certain genetic variants. But what people might not realize is even among those without a known family history, we are now able to detect a genetic cause in quite a few of those people. The estimates change depending on the papers that you read and certainly will evolve over time, but at least 10% of those individuals have an identifiable genetic cause as well. And so you'll often hear us talk about family history of ALS and quote-unquote related conditions. So what the heck do we mean by that? You got a little bit of a preview in the last talk. One of the main things is frontotemporal degeneration, or FTD. There can be overlap with FTD spectrum disorders and things like Parkinson's, for example. And so I'll tell you a little bit more about family history in a few slides. And so, again, just to reiterate that FTD and ALS exist on a spectrum. People can have symptoms of one, the other, or both. This is due to sometimes a shared genetic overlap. Certainly there's shared pathology. If a person who is affected goes to autopsy, we can see some of the same proteins building up in the brain. And so just for those of you who may be less familiar with FTD, just wanted to give a quick refresh that as we were hearing in the last talk, it's a defect of executive function, not necessarily memory loss, which is what many people think of when they hear the word dementia. This is a condition that really causes drastic changes in behavior, personality, language, and sometimes movement, and it strikes when people are much younger than when people think of dementia, right? It's an earlier onset condition that often happens when people are in the prime of their work life, their family life, and so it can have significant impact on a person in the family. And so I just wanted to give a plug about the pitfalls of family history here. So I'm a genetic counselor, and this is one of our first tools that we pull out in the toolkit to figure out, what's the likelihood there could be a genetic cause, but it's not a perfect tool. FTD and ALS can be challenging to diagnose, and there can be misdiagnosis. So somebody could get a diagnosis of something like MS or bipolar disorder or something else that may have overlap. And there can be missed diagnoses. So especially if you go later back in the older generations, people might not have made it to the right care team, or they might have been institutionalized, for example, and they might not have ever come to the right diagnosis. Sometimes there's just limited health information in a family, whether that's because people aren't communicating, maybe there's some stigma around certain diagnoses, like FTD, for example, or maybe someone's adopted and they have no clue what's going on in their health history. There can also be, a small family size, or people may die younger of other causes like heart disease and cancer. These things also exist in the world. And so it could be the fact that a family history that appears negative could just be masked by some of these other factors. And so the other thing that I want to point out here with this image is that, sometimes people can say, I don't have family history of ALS, and therefore I don't think this is likely genetic. But if you start to then explore, there could be family history of other conditions that people might not have put together could be related to ALS, like Parkinson's or dementia. So all of this is to say that family history is an important tool, but it's not the end-all be-all when we're figuring out what's the likelihood that you could have a genetic form. And our understanding of the genetics of ALS has been exploding. There's now over 30 genes that we know can cause ALS spectrum disorders, and I love these graphs because I'm not the one who puts them together, but they're excellent. So I always encourage you to find these papers that have these great diagrams. And so many people have heard of C9orf72, SOD1, FUS, some of the ones that have been more in the spotlight because of either ongoing trials or they're more common. But there are many other genes that we know can cause ALS when there's a pathogenic or disease-causing variant, and there's more that will likely be discovered. And so the other piece to this is when you have a genetic cause found, what the heck does that mean for the family, right? And so most of the genetic forms of ALS are inherited in what we call an autosomal dominant pattern. Not all of them, but most of them. And autosomal refers to the fact that this can affect an individual of any sex, and dominant refers to the fact that only one of the two copies of the gene need to be impacted to cause the condition. And so if a parent is found to have an autosomal dominant condition, each child has a 50%, so a 1 in 2 chance to inherit that same genetic condition. What that means in terms of the likelihood of them developing symptoms depends on a different concept called penetrance. Many of the genes that we know can cause ALS do have variants with high penetrance, meaning if you have this genetic difference, there's a high likelihood symptoms will develop. But the more we study these genes, the more we're finding reduced or incomplete penetrance for some of the variants. When a genetic cause is not found, most people fall into this other bucket, what we call multifactorial inheritance, which is a fancy way of saying there's more than one factor that influences why disease develops. And so if you take a look at this jar model, if you have to fill the jar up to get ALS, we're all born with some inherent genetic risk factors we probably can't even measure yet. And those are those little small yellow balls. Maybe someone's born with this bigger yellow ball, a slightly higher genetic risk factor, but that alone is still not enough to fill the jar to cause ALS. Maybe we've got environmental exposures, trauma to the body, these other blue factors in there. And so the question is, how many factors does it take and what are those factors to cause ALS? And so many people fall in this bucket where we just don't know. There's a lot of good research going on in that space, though. And so when we talk about genetic testing, I like to broadly categorize this into two main types. The first is diagnostic, and the second is predictive. Diagnostic genetic testing refers to the process of testing a person who's already developed ALS or symptoms of ALS and trying to do testing to understand why that's developed. And often that's the first place we start in a family wherever possible. Because if you can figure out the genetic cause of a person's ALS in the family, then other family members can decide if predictive genetic testing is right for them. With predictive genetic testing being the process of testing a currently unaffected individual, looking to see if they've inherited risk to develop this condition in the future, which is a highly, highly personal choice, and we'll come back to that. And so I highlighted the diagnostic genetic testing piece there, not just because it's often where we start, but also because I think that's where most of the attention has been lately in the literature. There's been a big push on the importance of offering genetic counseling and testing to all persons with ALS, particularly in the United States. We just had a guidelines paper published by my colleague Jennifer Rogenbach, who's going to speak later on at the symposium on the guidelines that were published. So if you stick around, check out her talk. She's fantastic. But basically, there's been work that's shown that because family history is a limited tool, and you can have a genetic form of ALS regardless of whether you have family history or not, and because a genetic diagnosis can have benefits to the person diagnosed and to the family, it's important that everybody is at least offered this service. And so not everybody might want it, but certainly it should be offered. And so genetic counselors are a limited resource, as we'll talk about later, and we need to think about not just how genetic counselors can be offering this to everybody, but how clinicians like neurologists or nurses can also integrate talking about genetics into part of their care. And so these are just a couple screenshots from Jennifer Rogenbuck's paper on the guidelines, showing some of the genes we feel are important that all persons with ALS should have the ability to have tested, and some of the key counseling highlights. But you check out her paper or her presentation for more. I also want to point out that, when we talk about what genes are the most common in ALS and things like this, a lot of the research has been done mostly in European white populations, and we are in a global meeting right now. So I think it's really important, especially here, but in general, to call attention to the fact that there is diversity in the geographic sort of spread of genetic variants that can cause ALS. And we still have a heck of a lot to learn about, what are some of the more common variants in these understudied groups. And that has implications not just for the diagnosis and for the, care of the person and their family, but it's going to become incredibly important as more trials are developed. And where are we allocating funding for some of these these gene-targeted therapies? Are they only going to these more studied variants, and are those more studied variants, unique to a certain population? And it's important, that we recognize that genomic medicine is not just a thing of the future. It is here. And the top of the screen, you'll see my colleague from Penn, Dr. Colin Quinn, administering tofersen, which is a now approved therapy by the FDA in the United States. There has been a huge increase in the amount of gene-targeted drugs, not just, in the neurologic space, but more broadly. And hopefully there's more to come. And so I think it's important that we recognize that increasing access to genetic counseling and testing is now even more important, given the fact that this can have treatment implications for people. But there's more to a genetic diagnosis beyond treatment. And so for some people, getting an answer as to why they have developed their condition is in itself a huge relief, just to know, to have that answer as to why. It can end a diagnostic odyssey. We all know here that ALS can be incredibly difficult to diagnose. It can take years of doctor's appointments and invasive and costly procedures. And so if we can, shorten that process, why not? It can provide anticipatory guidance for the person diagnosed, what to expect in the future. Is this a genetic form that's also linked to FTD or Parkinson's or other symptoms? It can help us hone our access to more appropriate support, research, advocacy resources that are more targeted. And really importantly, this can also inform the family. And so, I had mentioned before, predictive genetic testing is something some people may consider, whether they want to know their risk status. We can't do that for a person in a family really accurately unless we've found a genetic diagnosis. We can use family history to give us a guess, but having a genetic diagnosis in the family can really hone that risk. And it is a highly personal choice whether someone wants to undergo predictive testing, and it should really only be done in the context of genetic counseling because there are emotional, practical, legal, logistical considerations to be made here. People need to have the time and space to think through, first of all, am I comfortable having this information in my medical record? There are laws in the United States that have some protections, the Genetic Information Non-Discrimination Act, for example, but there are limitations. So that law does not protect against discrimination based on your genetics for your life, long-term care, or disability insurance. And there's, similar protections and things in some states, and this may, differ globally as well. There's a couple of papers out of Miami's group, Dr. Benatar has, with some information about other countries as well, which I apologize for not summarizing here. But people have to ask themselves, do I want to know this information? What will I do with this information? Is it going to make me anxious? Is it going to make me empowered? Am I going to use this to make different decisions about planning for my future, whether that's my career, my retirement, how close I want to be to my family? Is it going to change my reproductive planning or not? There are some technologies that exist to try to avoid passing down a genetic difference in a family. None of them are perfect solutions. None of them are cheap. None of them are easy. But these are things that people weigh among many other things when they decide, is this right for them? And so I mentioned the importance of genetic counseling. Obviously, I'm biased. I told you I'm a genetic counselor. But I think it's really, really important that we, make sure people have access to this service if they want it, especially when they're undergoing the predictive consideration. And so genetic counseling really is a process of helping people adapt to this medical, psychological, and the informational needs related to a condition in the family. And so as I mentioned, we take family history. We use this to help us figure out what's the likelihood of a genetic cause. And then we help, figure out, is there the most appropriate test? Do you want to pursue this? Help you make the best decision based on your needs and your goals. But genetic counselors are a limited resource, as I mentioned, with growing demand, especially now with the increased treatment and things like this, or genetics-focused treatments. And access to this service really differs based on where you're located, which seems to be a common theme for the conference. And so we really need new approaches to streamline this service and to make sure people have not just access, but equitable access. As I mentioned that this is only going to continue to worsen a gap in access to appropriate care and treatment. And so today, we want to talk to you a little bit about some innovative ways that we're trying to address the gaps in care. So first, I'm going to turn it over to Lauren to tell you a little bit about the Les Turner ALS Foundation Decision Tool.
Thank you so much, Laynie. That was a phenomenal presentation, a nice recap, so we can talk a little bit more. I'm Lauren Webb. I'm the Chief Advocacy and Outreach Officer for the Les Turner ALS Foundation. Our foundation's been around 46 years, and we actually funded the SOD1 research and looking at that, and that was an area that we heavily focused on. We fund research, we fund clinical care, and we have a support services team who does direct service. So we talked a little bit at our roundtables about what keeps you up at night. Well, genetics. Access to genetic counseling keeps me up at night. I've been thinking about this issue for over 20 years, and it took a trip to Perth, Australia to find out about the work that they were doing there around shared decision making. And at that conference in 2019, I learned from our colleagues, Ann Hogden and Ashley Crook, about their tools that they were utilizing. I learned about a whole entire community around shared decision making. And we talked through about what could that look like within the genetic space. And during all these international meetings that you sit in on and you hear these little stories and these about research and what's coming down the pike, and we gleaned and we understood that there was a change in practice that was happening in the United States, a clear change in practice. It used to be that physicians would only offer genetic testing if you had a family history. Well, Jennifer Rogenbuck, who Laynie talked about, worked together with a large working group to come up with these processes and ways to think about genetic testing. And so we knew that was coming, and so we decided we're going to take the decision tool and help address the issue of not having enough access to genetic counselors and being able to provide people with information that they can read in their own homes, digest it, think about it, and really bring it to a conversation with their healthcare team. Again, the whole purpose of shared decision-making tools is to simplify the information. We don't go into a lot of numbers. We don't talk about penetrance. We don't go into all those levels of details, which will happen when you're talking with your genetic counselor, depending upon your specific interest. But then we also focused on gauging a person's understanding. We had interactive components around decision-making. We wanted to make sure that we clarified their preference. What matters most to you? And that was really important. And then we also, I don't know if this is actually true, but I'm just throwing there on the slide to be quite honest, but we do know from other literature that utilizes shared decision-making tools in other disease states that does help improve health inequities. It's clear. And we also know that when you look at maps, we had a nice presentation on maps, but when you look at health literacy maps across the US, and I can hone in to where I live in Chicago, and I can tell you which neighborhoods have a low level of health literacy. And they also have, we've been talking about zip codes and the zip code lottery. And for some people, it's very challenging, and those accesses to social determinants of health. So if you can't even get in to see a primary care physician, you can't get to a multidisciplinary clinic, how are you ever going to have a conversation about genetics? And so we really set off at the foundation on a journey of looking at health literacy and shared decision-making to improve the quality of life for people living with ALS, and we wanted to facilitate conversations. So on May 1st, we launched our genetic decision tool, which is the first of its kind in the U.S. to help people make informed decisions about their care. And this was really important for us. We started off, the first person I called was Jean, who's in the room here, who has presented, and said, we have this idea, what do you think? And so then from there, we started talking with more and more people in the community. We did informal interviews with them and kind of work through. And then we also went to the literature to better understand what is the current practice, what do we need to think about, and that's how we move forward. And we involve people living with ALS to do user testing, as well as help us with the writing of the copy. And what was critical through this user testing, which I'm not going to belabor today because that's a whole nother talk, but people were not aware that ALS had cognitive involvement. And I think that's really important. We did, from our socialization or our testing with other colleagues, we learned from a caregiver living with ALS who said, whoa, 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 you're giving too much information about FTD. Why don't you just focus on the basics? And we revised that because people are trying to digest a lot of information. We gave them a wee snippet, and so that they understood that this is a possibility. And so again, the whole purpose of the decision tool is to really walk through some of those things that Laynie talked about. So we walk through the benefits and the emotional challenges in a very neutral language, because everyone has different reactions to genetic testing. We wanted to allow for them to work through their choices. So please, I encourage you to scan the QR code, take a look for yourself, walk through the tool. We've had over 900 views of the tool so far since May, and I think it's really, I would implore you, my take home for you is to log on and to take a look at it and to let your multidisciplinary clinic teams know that this is a service that's available for them, because not all multidisciplinary clinics have genetic counselors. So our current modules for the decision tool, just to promote it actually, but to kind of tie the conversations that we've been having today around non-invasive ventilation. So we have a decision tool for that where people can click on, again, focus on what matters most to them, and the feeding tube. We do have hospice and palliative care organizations that we work with that actually walk through the tool with the people that they're working with to help drive those conversations. And coming in 2024, we're working on genetic testing for people at risk of developing ALS. And so, more to come later with that. And we're also working with, you heard from Allison yesterday about the clinical research learning ambassadors in the States. We're working with her and her team to help simplify clinical trials and to ensure that people have an understanding of what is clinical research and how they can participate. So we're going to be working on that, and we're going to develop a decision tool around that. And so I just wanted to highlight a couple other educational materials that we have. Laynie is going to be speaking at our ALS Learning Series, which is a webinar that we have in January, and she's going to be giving a talk called Conversation with Genetic Counselors, Could the ALS in My Family Be Genetic? And so this is a patient-facing webinar, so I would encourage you, if you have families and you want to introduce that topic to them. We also have Jennifer Rogenbuck's, if you're not sticking around for the larger scientific meeting, we have Jennifer Rogenbuck's talk where she talks about the standard of care around genetic testing and the new options. And then we also have on our ALS Learning Series a talk from a few years ago, which will need to be updated, but it's still good, around family planning from Lisa Kinsley at Northwestern University. So because Casaldi wasn't a thing at that time. So I would encourage you to take a look at this information, and it is an honor and a privilege to be able to work with families to co-produce with them the things that they need at the right time, and that's what the Les Turner ALS Foundation is committed to doing, and that's what this community is committed to doing, And we can only do that by working with each other and learning from each other. So thank you.
Thanks, Lauren. So my name's Paul Wicks. I'm a neuropsychologist, and so it's been music to my ears hearing some parts of the last couple of conversations that we need to have more understanding about FTD and cognitive dysfunction, but it's also still quite sad how many people aren't being told. And my story with ALS actually goes back 20 years now, when in 2002 I started as part of my PhD at King's College London researching cognitive dysfunctioning and neuroimaging in both sporadic ALS and also people who carried a SOD1 mutation. And back then it took me about 3 years just to find 7 people with a SOD1 mutation in the whole country. So you can imagine how challenging that was. But at the time, there was a lot of denial that cognitive dysfunction could be an issue. So I spent a long time working on that. And then I moved more into digital technology, worked at a company called Patients Like Me for a number of years, which hosted large online communities for ALS. But my position in this field changed a little while ago, and I've gone from carrying a researcher passport to also having a caregiver passport. So this is my father-in-law. 10 years ago, he was diagnosed with a very slowly progressive form of ALS by some of my friends, by some people I've done karaoke with in Yokohama, which puts you on the other side of the table and is very unusual. We've been very fortunate to be supported by a wonderful care team. But, I want to acknowledge that, as a clinician, a clinical researcher who had read every piece of paper about ALS up until this point, I thought I knew something about ALS. Turned out I didn't. So that's my eldest daughter, and you can see her neurogenesis in contrast to his neurodegeneration. He is currently less than a 10 on the FRS, but you can see he does have some residual function to make sure he has a glass of whiskey to hand at all times, which seems to be underutilized as a mechanism. So when we went through this process, we did have the opportunity to undergo some genetic testing as research to see if he might be eligible for one of the studies that was coming through at the time. And clearly we were very well supported by an excellent team, and the fact that I knew a fair bit about this was a help. We were very fortunate in that of the genes that he was tested for, he was negative. But it took a few months for those results to come through. And so I knew in excruciating detail the size and shape and weight of that sword of Damocles hanging over my family. And I think there was a clear choice we had when we tested negative to either go, phew, thank goodness for that, we've dodged a bullet. But particularly as I was locked away in my shed during COVID, it occurred to me the great unfairness and the unjustness of, well, what if you can't text Martin Turner on WhatsApp to find out what we should do next? What if you don't speak English as your first language? What if genetic testing isn't widely available? And so I started looking to some of the tools I'd used in the past of using digital technologies, of working with patient advocates to say, okay, what is a system that we could develop that could be more equitable, that could scale to more people, so that if you were in situations like this in the future, that everyone would have a more equitable shake at better care. So we started, as you always should, by talking to the people most affected, so by people who have ALS, who have symptoms of ALS, or people who are at risk of genetic ALS. When I started research in the field, there wasn't even a good term for people who carried the gene. The word pre-symptomatic was still used, which I think is highly problematic as it sounds deterministic. But as we started speaking to people, a very consistent pattern came from both the scientific literature and from talking to people, whether in group settings or individually, that there were a great deal of fears, that there were some really significant burdens. Work that Christiana Salmon has done in places like Canada show that even in a developed economy, you could have a different answer if you see a different clinician in the same hospital. So it's not just a zip code lottery, it's a clinic room lottery. That shouldn't stand, that mustn't stand. Clearly, experts have expertise, but you only see them for about an hour a year. And who else is there in that part in between? So my experience in patients like me was that, at 2 a.m. in the morning, it's other people like you. It's other people who have been there, done that, worn the T-shirt, walked a mile in your shoes, had that awkward conversation, had an awkward Thanksgiving where you're disclosing your genetic status and maybe someone at the table doesn't want to, or is angry that you did, or complex conversations about family planning that, clearly can be very emotive, but shouldn't be suppressed. So as these sort of came through, we sort of thought, well, clearly we'll never be able to solve all of these, but what we might be able to do is to develop systematic means to plug some of these gaps. We did have a careful look in the scientific and clinical literature. We've been very well supported by a scientific advisory board to sort of check, when there is good care in place, how consistent is it? And I think Jennifer Rogenbach's work is so important to illustrate that there's a great deal of inconsistency in the space about who is offered testing, which genes we test. So this heat map, for example, if every country was consistent, these would all be red. And it just sort of shows that, different tests were available at different times. It's slightly out of date, but I imagine that the principle still holds. Genetic counselling is so important. And, we've heard anecdotally of, in the UK, we've got 18-month waiting lists in some cases for genetic testing. Genetic counselling could be a 5-minute phone conversation, and we've heard all sorts of horror stories, frankly, about how people receive their results. People got voicemails. People got text messages. People got a nurse calling them up saying, good news, it's positive. It's a disaster. And, I think it's so much more needs to be done and could be done better. So the solution we've attempted to put out there for some of this is called Light the Way. And the aim is to sort of light the way through the darkness that the people find themselves in, through a variety of things. So for one thing, from genetic education, this stuff is complicated. Very complicated, and the more you look into it, the more complicated it gets. So we have a series of videos and modules that Laynie has produced and is the star of the show in, to ensure that people have a good grounding, a good understanding, no matter at what point they've come to this. We're going to connect them to peer support. You're probably aware of End the Legacy, who have weekly drop-in calls for research and advocacy, but they also have monthly groups run by social workers to deal with so much of the mental health issues that go into this, the emotional work that needs to be worked through here, and the understanding that you can only get from other peers. Family planning is so crucial, and in part this work was inspired by someone called Daniel Barvin, who's been very public about him and his wife's journey with IVF, and that baby picture of his cute little baby is really one of the targets that we're aiming for, that for those people for whom it's suitable, for those people where it's appropriate, we want to make sure people have got all the information. Genetic counselling should not and must not be restricted to, luck of the draw and what have you. And also we want to make sure that was available both pre-test, to understand if you want or need testing, and post-test. Even many people who we speak to who are in studies, who've seen their results, haven't fully got all the information, aren't fully able to convey that to their family members, and that's a real gap. Genetic testing should be possible at home. It's quite easy now to send kits in the post. I mean, if you've had 23andMe and you've spat in a tube, it's a very similar technology, right? We don't necessarily need to bring people into hospital, scary setting, blood draw, all the rest of it. It's so important to connect people to research studies. If we don't know if someone's got the gene, we can't put them in the trials. We can't put them in the observational registries. We can't put them in DALS and PREFALS and ACORN and the C9 trial we're discussing in 2 hours, right? All these types of things are only possible if we have systematic screening, systematic surveillance of all these things. And then, of course, in the US, we have a gene therapy. And, I hope that becomes more widely available at other places. But one can only imagine if you don't happen to live near Boston, near San Francisco, and you weren't tested, then, time is neuron here. If we can't find people that are eligible for these therapies, we are wasting whole generations of folks' time that could really be treated. We also knew from the get-go that this could be multinational. Facebook and Uber and all the software that you use works in multiple countries if it's coded from the get-go to work that way. So we've developed Light the Way for the UK and the US initially, and in the US it's going to be available in both English and US Spanish, because one of the inequities that I think Laynie mentioned must be about health equality and language. So the way it'll work is everybody's going to have access to these education and peer support modules. If they decide that they would like to go ahead with genetic testing, everybody's going to get pre-test counselling. That will be delivered sort of by video conference. They'll have their spit kit delivered to them at home if they decide to go ahead with that, and then the results should come back. We're hoping much, much quicker than we get, certainly in the NHS. Just to say, it's a research use only test for the initial screen. If it turns out to be positive, we will also be double running it through a clinically validated, clear, compliant test, so that the results that come back to the person will be clinically actionable if they ever give it to their care team. And the return of those results will come from a genetic counsellor, nearly always the same genetic counsellor who did that pre-test training. So this is not an email, this is not a text message. Clearly, if people are negative, like our family was, there's some degree of relief they can get from that. It doesn't mean they're necessarily 100% out of the clear. And clearly these people may have survivor's guilt. Many of them will be caregivers to brothers, nephews, cousins, etc. Right? So I think they're still part of our community. They're still a really important resource for us all. If they're positive, we want to make sure they're plugged into trials, studies. If there's a therapy available for them in their country at the time, we want to make sure they have access to those. And so we want to make the point that there's a lot that can be done. Some people will have a variant of unknown significance. We want to engage those folk as well and make sure we can continue to work with them. So this is launching now, and we're going to be here all week. We have a booth at the main conference. It's bright orange, so you probably can't miss it. But we also just don't want to say this is a thing we're trying. We also want to study how we're doing as we go through it. So as part of a research study, we're going to be looking at the anxiety, the depression, the sort of fear of the stress, mapping out this sort of Damocles feeling as people come in at baseline, but also 3, 6, and 9 months later as we compare different cohorts that are untested, that are positive, that are negative, or that are uncertain. And the reason for that is part of this variation that I hear comes from individual clinicians and teams and their personal beliefs. If it was me, I wouldn't get tested. Okay, that's fine for you. That doesn't necessarily mean you can generalize that to everybody. And one of the fears is, well, if we told these people, of course, they'd all be incredibly depressed and might have suicidal ideation. That would be a net worse thing. Well, we need the data. We can't just assume that that's the case. And so this study, the Beacon study, is intended to gather that data, to feed that back to groups like the genetic counsellors to actually see, because we know in BRCA, we know in Huntington's, clearly when people do get very distressing news, that's a very difficult situation for them. But over time, they incorporate that into their narrative of their life and they make decisions. The vast majority of people surveyed on this do not regret having found out the results of genetic tests, but we want to continue to check if that is the case through these cohorts, and that's something we'll be doing. So what does success look like for us? Well, this is initially funded by a grant from the UK government. We're able to hopefully educate about 1,000 people across both countries. We're looking for about 150 people to get the genetic testing. But we're really hoping that this sort of program will not just let people know about the results, but actually empower them, inform them, help their families to understand what this really means for them. Clearly, we couldn't do this alone. We've had fantastic support. We're so lucky to have a scientific and patient advisory board that are really some of the leaders in the world on this. We work very closely with End the Legacy. And this technology is made possible by a group of free-range geniuses out of Cambridge University called Sanogenetics, who have made all the technology possible. So, yeah, we're hopeful this is an initial approach and will inspire other people to try other innovations and other approaches wherever they may be. Thank you.
Okay, just 2 quick slides before we go to questions. So we would be remiss to not put up some additional resources for genetics specifically in ALS FTD, some of which have been highlighted along the way, but I'm stalling here, so if you want to take photos, get your phones out now while I'm still killing time, letting you look at this slide. I will also put in a plug for this slide. You see the Penn Familial FTD ALS Conference. That's my baby, my pet project. We've now done this this will be our 4th year. We're going to have our 4th conference in February, so save that link if you want to save the date for that. And also a special shout out to End the Legacy, which we have highlighted throughout here, the first group dedicated to genetics and people who are at genetics risk. So everyone, round of applause for End the Legacy. Yes, doing the good work. Okay, and so where do we go from here? We've spent a lot of time highlighting some of the problems with access and some of the solutions that I'm really proud of my colleagues for working on. This has been some incredible work. But some other things we wanted to highlight is in the US specifically, genetic counselors are not Medicare recognized providers, which has a huge impact on people's ability to access us as providers. So if you are part of institutions that do lobbying or policy and you want to advocate for your institutions to sign on to those policies, please let me know. Please go do that. And both in the U.S. and globally, there's other things we can do. We need to continue to spread awareness, both through advocacy groups, but through clinical care teams and things like this. Alternative service delivery models still need to be developed, so how else can we streamline this care? We need to work on, translating these resources that have been developed. And we need to make sure that research opportunities are given to people of all backgrounds. And I'm on my tippy toes here. I think that was my last line. Okay, and so with that, here's some references. I'm always happy to share those slides. Thank you so much for your attention, and we're happy to take any questions.
Laynie, Lauren, and Paul, thank you so much for a fantastic session. This could have gone on all day. I have a lot of comments and questions, but I haven't got time for any of those. And everybody in the room can catch them around for the rest of the day. But we do have one quick, hopefully very quick question from Richard online, I think.
There were two comments, and I'm going to put them both together. From Lynn at ALS Problem Solvers, she said, one of my genetic tests had an asterisk. It was different from the norm, but bravely proclaimed as non-pathogenic. My doctor dismissed it, so I didn't get counselling. 3 years after my test, I have not found any information about my specific typo. How often does this occur? And the second point is about ethics from Rachel Thompson at Brighton Sussex Medical School. Just had a look at the tool, which looks great. I would love to have something similar in the UK, as some of the info is different, especially the time taken for results. One thing that worries me is how ethical it is to offer testing to someone when they may not live to see the results. The current wait in the UK NHS is 12 to 18 months.
So neither of those are quick.
Yeah. But I can be as quick as possible. So regarding the typo or variant without a ton of information, if it's called non-pathogenic or benign, likely benign, versus if it's called variant of uncertain significance or VUS, those are different things. But there are many people who receive these variants of uncertain significance or VUSs, and many of them are unique to that person. They might not have been reported in the literature before. There might not be any information to learn about it. It is common. It is something that a genetic counselor or a genetics-trained expert can help guide you through. Sometimes there's follow-up steps you can take to try to clarify the uncertain variant, like testing other affected relatives if they exist, if anyone else was affected and they're living, or doing follow-up functional studies or literature reviews, things like that. But sometimes they remain uncertain for a long time. And sometimes we can use what we do know to say, this is uncertain, but we're less suspicious of it, or this is uncertain, but we feel that this actually could be causal and we're going to keep an eye on it. And so that's my take on VUSs. And then in terms of the ethics of testing when someone may not be alive to learn the results, that's a heavy hitter. That's a tough question. I think that, so in the US, most results, if you order clinical testing, typically results are back within about a month. So, certainly people can progress that quickly, but, with wait times before you can even get testing, that process can lengthen. I would say even if the person may not live to see the results, there could still be benefits to the family in getting that information. And so that's why it's really important before a test is ordered, you talk about the potential impacts of the type of results, both for the person diagnosed and for their relatives, and you partner with them. Who are we allowed to disclose this information to? Because they might say, if I'm no longer living, I still want my spouse or my adult child to have this information. So certainly the number one fix would be to speed up the testing process, and really that means speeding up the initiation of the testing, not really the test itself, but when you start that process, but also being conscious even from the get-go of who are you able to share this information with on the back end.
All three of you. Sorry.